This is a class of pharmacotherapy of shock. The literal meaning is drugs which are used in the shock. Coming to outline of the topic, little bit history, classification of the shock, and clinical classification, warm and cold, and the management of shock, fluids, vasoactive agents, and the blood products, and little bit on refractory shock and the summarizing. Coming to the history, the term first shock used by Professor Leedran, which in French was push or impact. Then coming to the resuscitation part, first they used, as Vamshi sir has told, normal saline by Hamburger, Sydney Ringer's lactate. After that one, first major break came in 1899, Kreil. He found that the decline in blood pressure could account for all the symptoms of shock. Then regarding classification, Alfred Blalock has classified shock into hypovolemia, vasogenic or cardiogenic and neurogenic. Then Professor Wilhelmich again reclassified it. And then coming to monitoring, Swarna in 1970, and the little updated of that one, thermistor near the tip of the catheter to calculate cardiac output. And 18 we came to monitoring of mixed venous oximetry. In 19s we came to right ventricular volumes introduced, and fourth generation in 2000. Now the maybe I can say golden era with all focus vexes of monitoring. Coming to definition, shock is defined as a state of cellular and tissue hypoxia, either due to either reduced oxygen delivery or increased oxygen consumption or inadequate oxygen utilization or any combination of these processes. The most common finding is that there is circulatory failure manifested as a hypotension, but it is crucial to recognize that patient in shock can present hypertensive, normotensive or hypotensive. This is a clinical classification. Hypovolemic, maybe hemorrhagic loss or fluid losses like in GE. Cardiogenic, maybe mechanical or in like MI. Obstructive, where cardiac tamponade and pneumothorax or massive pulmonary embolism. Distributive, most common, septic shock. Neurogenic, any cervical cord or above dissections, and the anaphylaxis. Just this is a bedside or clinical, we can say, classification: cold shock and the warm shock. Cold shock, this is a cardiogenic. Whenever there is a decrease in the blood pressure, decrease in the cardiac output and stroke volume, heart rate, that's the right side. For compensation, vasoconstriction, which is increase the resistance to blood flow. The overall is a decreased blood flow and decrease the perfusion, which is manifested as heat. This is a warm shock. Then the cold shock. Then coming to warm shock, the most common is a septic shock, which due to left panel you can see that maybe cytokine storm or attaching to the toll-like receptors and very mediators leading to endothelial damage, activation, and everything leads to vasodilation. End will be the increased blood flow and the increased blood vasodilation and appears to be warm. Then coming to the management of shock, there is a ABCD, that airway, breathing and circulation resultant of resuscitation, and the fluid therapy, vasopressors, antibiotic and control of infection, nutrition, respiratory support, transfusion and treatment of specific terms. My scope of the topic here is the fluid therapy, vasopressors, and the total treatment depends on the cause, but it aims to expand vascular and interstitial fluid volume and so improve tissue perfusion, increase oxygen delivery and consumption, and support vital organs. This slide the management vasodilator, like in septic shock, use of inotropes and vasopressors and antibiotic. Cardiogenic, reperfusion and mechanical support like IABP. And obstructive, severe PE thrombolysis or cardiac temporal thoracocentesis, and hypovolumic shock if it is a hemorrhagic shock, transfusions. Coming to the fluid therapy, there was an excellent talk by Vamshi sir regarding that. But two or three slides again the fluid therapy. The primary objective of fluid therapy is to increase ventricular preload, which is on the only response if it is on the steep part of the Frank-Starling relationship, and increase in the preload is expected to cause a rise in the cardiac output. The mechanism in sepsis is ventricular preload can be reduced by two distinct mechanisms. One is the intravascular volume depletion and the venodilation. Both factors will result in a fall in venous return and the preload. Then due to leads to circulatory shock consists of 4 phases, and each phase has different goals of fluid therapy. Like two acronyms describe the stage of shock are resuscitation, optimization, stabilization, and the evacuation or de-escalation. And second is the other term. The ROSE was evaluated in the neurosurgical and post-operative patient. The second one is the SOST, salvage, optimization, stabilization, and the de-evacuation and resuscitation, which are used in the ICU. Then the fluid, before lecturers told like it should be like fluid stewardship. It should be based on the drug, dosing, duration, and the de-escalation. Actually, first we have to choose the right type of the fluid. Already we have many trials, and previous lecture also told. First one is the SMART trial. Crystalloids are as an initial fluid of choice in the resuscitation of severe sepsis and septic shock, which is SMART trial. And even surveying sepsis guidelines also says that we'll go with the crystalloids. Then initial fluid trial in the patient with sepsis induced tissue hypoperfusion with suspicion of hypovolemia to achieve a minimum of 30 ml per kg of crystalloids. It's a strong recommendation, but low quality evidence according to sepsis campaign. This 30 ml, as previous lecture told, it can be taken to 3 to 4 ml per kg. This 30 ml actually came during the cardiac anesthesia. They used to preload with the 30 ml per kg before doing cardioplegic. Next is the fluid challenge technique can be applied when fluid administration is continued as long as there is hemodynamic improvement. Recent trial ongoing is the Andromeda shock, which is comparing capillary refill time guided resuscitation versus lactate guided resuscitation. In sepsis campaign, we are comparing the lactate clearance. More than 20% of the lactate clearance is inadequate of resuscitation. But now this trial is ongoing. This demonstrated an association between lactate based resuscitation and higher mortality if capillary refill time was normal at enrollment. This is say that if capillary refill time is normal at the enrollment time, if you give more fluid to clear the lactates, they may be landing in the hypervolumic state, which is increasing the morbidity. Then comes to the if hypotension persists despite hemodynamically target administration of fluid, ventricular preload is less likely the issue. Then becomes the transfer to ICU and initiation of vasopressor is the advice. Then my second topic, then coming to vasoactive medications. These are classified and based on the whether it is acting on the vascular tone or acting on the heart. Either it is a vasoconstrictors, heart increasing the contractility or rate. They are classified as pure vasoconstrictor like phenylephrine and vasopressin, and inoconstrictor dopamine, norepinephrine and epinephrine. Each of these medications act as a vasopressor to increase MAP by augmenting vascular tone. This inotrope also includes the inodilators, where dopamine and milrinone. There it dilates the vascular system, both pulmonary vasculature and the systemic vasculature. And the inoconstrictors, dopamine, norepinephrine and nephrine. These inotropes act by increasing cardiac output through enhanced contractility. Then inodilators also reduce the afterload from systemic vasculature. Coming to each effect, This is depend on the dose administered, but particularly apparent with the dopamine, we know that from alpha, D1, alpha 1 and beta 1 based on the dose. Then recent large scale clinical trials have evaluated vasopressors and determined that norepinephrine may be preferred as a first line therapy for a broad range of shock states, most notably septic shock. Even surviving septic guidelines also say that NORAD is the vasopressor of the first choice. Coming to the classification, this is a proposed classification where direct inotropic effects, peripheral vascular effects, what are called vasopressors, what are called the inotropes. Pure vasoconstrictor, phenylephrine and vasopressin. I know both contractility and the vasoconstrictors are norepinephrine, epinephrine and dopamine. More of inodilators are dobutamine and milrinone, and the vasodilators are NTG, nitroprusside and nesritide. Coming to the first drug, epinephrine acts on the alpha 1, alpha 2, beta 1, beta 2 and beta 3. Other name adrenaline, I used to remember as like adrenaline for all. We know these types where it is alpha 1 in blood vessels, alpha 2 presynaptic, beta 1 in heart, beta 1 in heart, beta 2 lungs, beta 3 is in adipose tissues. These epinephrine stimulate both alpha and beta adrenergic receptor, prominent action on the heart, vascular and on the smooth muscles. It has a positive inotropic action, positive chronotropic which increases rate, and vasoconstriction in many vascular beds, especially in the precapillary resistant vessels of skin, mucosa and kidney, along with marked constriction of the veins. Epinephrine increases the systemic vascular resistance by alpha 1 receptor dependent vasoconstriction, increases cardiac output by beta 1. As a result, epinephrine is especially useful for the treatment of acute LV failure during cardiac surgery because it predictably increases the cardiac output. And some side effects it can say, it can also increase in the blood sugar levels and increases the glycogenolysis in the liver. A transient increase in the serum lactate occurs, which can confound the management of the shock, as a lactate is used as a marker of tissue hypoperfusion. But the study says that these lactate induced by exogenous catecholamines does not appear to be associated with harm and usually return to baseline value within 12 to 24 hours. Then summarizing, it's the initial vasopressor of choice in anaphylactic shock, an add-on agent to norepinephrine septic shock, when additional agent is required to map to target an occasional and alternate first line if norepinephrine is contraindicated. If there is any increases heart rate may induce tachyarrhythmias and ischemia, especially in post-op like colostomies or any anastomosis surgeries. For inotropy, doses in higher end of suggested range is needed. Elevate lactate concentration during initial administration may use of lactate clearance goal. This may decrease mesenteric perfusion as in anastomosis surgeries. Then coming to the norepinephrine, it is a potent alpha agonist and relatively little action on the beta 2 receptors. Both systolic and diastolic pressure increase and MAP also increase. Cardiac output is unchanged or decreased and total peripheral resistance is raised. It's a constrict mesenteric vessels and reduce splanchnic and hepatic blood flow. Many randomized trials have shown the beneficial effects of norepinephrine in the management of shock and was chosen as the first one to start. Since the norepinephrine has a minimal chronotropic, that is a rate, it is useful in setting in which heart rate stimulation may be undesirable. It increases both diastolic and systolic. It also increases coronary blood flow and thus may improve the cardiac function indirectly. Norepinephrine is the first line vasopressor for all forms of shock with severe hypotension. Third one is the dopamine as an immediate metabolic precursor of NE and epinephrine. It has a various action based on the concentration. The most primary interaction of the dopamine receptor in the vascular, especially in renal, mesenteric and coronary beds. It increases the glomerular filtration rate, renal blood flow and sodium excretion. Then comes to where to use the dopamine, and is it beneficial in AKR, and the studies have done SOAP to severe uh, a SOAP2 study versus D. Baker et al. This first SOAP2 study says that they may increase in the urine output first 24 hours, but after 24 to 48 resuscitation, there is no improvement. The overall mortality is the same. D. Baker and associate was in pro of the dopamine. Then it also, and with the range of beta 1 receptors and the TAR receptors, at low doses inhibits the release of norepinephrine, which can cause acts of mild vasodilator, and it inhibits reuptake of norepinephrine in the presynaptic sympathetic nerve terminals, resulting in an indirect increase in the cardiac contractility and the heart rate. Then same I told, in the higher concentration it acts like a vasoconstrictor, but the cardiac output and peripheral tissue perfusion may not continue to improve. Then the point of interest is low doses of dopamine causes renal vasodilation and natriuretic effects that increase urine output, but the impact on creatine clearance and the renal blood flow varies, and the clinical sequence of renal dose dopamines remains unclear. No trial is shown this beneficial or mortality benefit. As a result, dopamine is no longer recommended as vasopressor support in septic shock, except in patients if you have Brady or who have low risk of developing tachyarrhythmias. And coming to phenylephrine, alpha 1 agonist, and it activates beta 1 receptors at higher concentration. It can be useful in situations where the systemic vascular resistance needs to be increased without any alteration in the cardiac parameters or contractility or rate. According to surviving sepsis guidelines, the phenylephrine is contraindicated in patients with septic shock, except shock persists despite use of 2 or more inotrope or vasopressor agent along with low dose vasopressin, or cardiac output is known to very high, or norepinephrine is considered to have already caused serious arrhythmias. Then other use of this phenylephrine is the valuable treatment of HOCM, because it increases the afterload of the left ventricle by increasing the systemic vascular resistance. Another important, vasopressin. These endogenously occurring peptide mainly act as an ADH by mediating reabsorption of free water from the collecting tubule. It has V1 mediated and resistance vessel throughout the circulation are affected. Like in smooth muscle in the skin, skeletal muscle, fat, pancreas and thyroid gland appear most sensitive with significant vasoconstriction, GA, tract, coronary vessels and the brain. Despite the potency of vasopressin as a direct vasoconstrictor, it has also induced pressure responses in vivo or minimal and only occur with vasopressin concentration significantly higher than those required for maximal antidiuretics. So, in the many trials found that, in the sick patient, patient who are on the support, the vasopressin levels are very low. So, to act that, the level should be more than the maximal antidiuresis. In the VAST trial in 2008 conducted that there is no mortality or adverse drug reaction when using low dose vasopressin in septic shock patient. In this VANISH trial, effect of vasopressin versus norepinephrine on kidney failure in patient with septic shock. Trial also compared NE with vasopressin and concluded that there was no mortality benefit or reduced adverse drug reaction in the vasopressin group. Then this is a summary of vasopressin. The vasopressin receptors on vascular smooth muscle cells are open as their concentration is low. As I said, vasopressin response is better in patients who have autonomic failure, which in case of septic patient who are sedated and paralyzed. And vasopressin potentiates the effect of norepinephrine. As the patient is already norepinephrine, you can start that vasopressin. Vasopressin directly inactivates potassium ATP channels in vascular smooth muscle, this is one of the cause for the refractory shock. It also blunts the increase in the cyclic GMP induced by the nitric oxide. Then coming to the milrinone, the primary advantage of the milrinone over the inotrope is that increases the heart contractility with significantly decreasing both systemic vascular resistance and pulmonary vascular resistance. These combination make most useful drug for the treatment of low output syndrome following cardiac surgery. It acts by inhibiting phosphorus diestrase, mimic like beta 1, beta 2 activation. This half-life is more than the other inotropes and quite effective in patients with prolonged chronic heart failures who have down-regulated or desensitized arrhythmic receptors or after long-standing beta agonist administration. Renal impairment significantly increases the half-life of milrinone, so maintenance dose should be adjusted according to the patient with the renal failure. It is shown to benefit in the decompensated heart failure, drug of choice in the high SVR and low cardiac output, but caution must be exercised in patients with low SVR or hypovolemia. The show because milrinone administration make them too hypotensive. Coming to the new, levosimendan, which has released with a bang in the market. That is a game changer like thing. The main advantage is an inotropic agent with vasodilator properties that is especially effective for the treatment of patients with acutely decompensated heart failure. It mechanism of action is it's a sensitize the myocardium to calcium by binding to cardiac troponin C. Other inotropes are they use the calcium, but here you only sensitize the myocardium. So this is a decreases the myocardial oxygen requirement. It has also vasodilator effect, result of opening ATP sensitive potassium channels in the smooth muscles to cause smooth muscle relaxation. These combined increase cardiac contraction and the peripheral vasodilation decrease both preload and afterload, thus improving cardiac output. This also has a cardioprotective effect because it opens the mitochondrial ATP sensitive potassium channels in cardiac muscle without a commensurate increase in the oxygen requirement. Levosimendan is also effective in presence of sepsis and septic shock. It improves the microcirculatory flow, renal function, hepatic function, and overall hemodynamics better than dobutamine in patient with the septic shock. It's a comparison of the levosimendan and the dobutamine. This is a trial, the Survive 2007 trial, which compared levosimendan to dobutamine in cardiopulmonary bypass patient, that failed to show any mortality advantage of levosimendan despite a reduction in BNP levels. This still levosimendan, they say it's a pleiotropic agent. It has vast advantages, but yet to prove or trials are going on. Coming to angiotensin 2, it is used as a vasopressor only. Actually, it has advantages as a rapid pressure response and consists of slower pressure response. Once you started, it will have the both vascular and cardiac hypertrophy and the remodeling. The disadvantage is 1 mg costs around 70,000. Then coming to the mechanism of action, it is altered if there is a peripheral resistance or altered renal function. First one, the direct vasoconstriction and enhance neurotransmission by increase NE release, decrease NE reuptake, and increase vascular resistance, increase sympathetic discharge, and more augmentation of catecholamines from the adrenal medulla. This all leads to rapid pressure response. And delayed one is the increased sodium resorption in the proximal tubule, release of aldosterone from adrenal cortex, and it helps in the direct renal venoconstriction and noradrenaline transmission in the kidney and increase renal sympathetic tone, which is shown as a slow response. In a randomized trial compared with placebo in patients who were already receiving high doses of NE with angiotensin to effectively increase the blood pressure in patients with vasodilator shock that did not respond to conventional vasopressor. This was shown in the Athos tree. Coming to terlipressin, this is a synthetic vasopressor analog with a greater selectivity to V1 receptor and a longer half-life. It is a drug of choice, hepatorenal syndrome with and albumin significantly increases creatinine clearance and the urine output. Because of longer half-life, terlipressin is often administered with intermittent high-dose infusion, 1 mg every 4 to 6 hours. And in the terlivap study, compared to terlipressin NE in cirrhotic patients with septic shock, additionally provides early survival benefit and reduce the risk of variceal bleed. To summarize it one, inotropes, vasopressors, coming to vasoconstriction, phenylephrine and vasopressin, and the vasodilation nitroprusside NTG, and to positive inotropic to increase the contractility, dopamine, epinephrine, and dopamine, and down is the dobutamine, and the pharmacological effects of vasopressin inotropic based on B1, alpha 1, alpha 2. The more 0 to 3 plus highest 4 places with the dobutamine and the epinephrine, and only pure vasoconstrictors, phenylephrine and vasopressin. This is a summary of the vasoactive agents. Based on what is your requirement, it's a failing heart only, or a problem with increased systemic vascular resistance or pulmonary vascular resistance. Based on that, we'll choose the inotropes. But most of the ICU, we see the septic shock patient. Obviously, the first choice will be the NORAD. It is, now trials are saying that once you reach the in the intermediate dose of the norepinephrine, then go on for dual inotrope support or the multimodal inotrope support. And other slide will be the blood transfusion. If I treat the blood as a drug also, the same thing, massive transfusion protocol. Here we have taken, like, if you have the TEG and rotum, it's a pack of one. First we resuscitate with the fluids, if not, then go directly to the blood products only. In the middle box you can see that order transfusion pack 1, like PRB 6 units, FFP 4 units. If again reassess, second order transfusion pack of 2, then it comes the platelets and the cryoprecipitates. Then according to, again with the help of all the coagulation profiles, we have to see that one. Another thing of my topic is the refractory shock. When you say the refractory shock is that when you use the high doses of one or more vasopressors, that is norepinephrine or epinephrine, more than 0.5 to 1 microgram per kg per minute, which is this is complicated, the 6 to 7 cases with shock, with short-term mortality up to 83 to 94%, and few clinical studies to guide management. We cannot, there are no guidelines regarding this refractory shock. Every ICU has their own protocols. When to add second one, third one, any resuscitation. There's 2 slides on this one. Why the refractory shock is pathological vasodilation characterize most cases of refractory shock occurring via vascular hyporesponsive to catecholamines due to receptor desensitization or inflammatory vasodilation, maybe systemic acidemia, ionized hypocalcemia, and relative deficiency vasopressin and the corticosteroids. The slide shows the mechanism of the refractory shock. The last one is you can see impaired responsive to the catecholamines, whether the ATP sensitive potassium and large calcium channel activation, which is this on the vascular smooth muscle, or excessive nitric oxide release or CGMP inhibition, or superoxide radicals. All the three first one can lead to altered microcirculated flow or shock-like system of vascular hyperreactivity, or third one is vascular smooth muscle relaxation or other metabolic parameters, hyperglycemia, hypocalcemia, or corticosteroid deficiency. All the whole is leading to impaired responsive to catecholamines and leads to refractory shock. To rescue therapy for refractory shock, first one is a glucocorticoids with a hydrocortisone. We have 2 studies, adrenaline and approaches. One is 200 mg per day, that is 50 mg QID, and approaches 50 mg per day. These approaches will have fluorocortisone 50 mics. Both studies doesn't show any mortality benefit, but it will give time for any other corrections or anything. Our institution protocol, before initiating, we send the steroid levels. Here we take cutoff of 33 cortisol levels. Second is a patient persistently any acidosis, maybe not in AK but acidosis, then we will give with the supplement the bicarbonate. The trial is a bicarb ICU, it doesn't show any mortality benefit. And other thing is AKR, we can go for renal replacement therapy. And role of calcium, both Victas and citrazole. In Victas it is a combination with thymine, other thing. Citrazole, in Victas it show, in sepsis, severe sepsis, it shows some benefit but not significant. And the third one is a nitric oxide inhibitors like methylene blue. Here in our institution we use the methylene blue. Once we start both, if not support of dual inotropes, both NORAD and the vasopressin, and more of there is septic shock. Dose we used to take 1 to mg per kg. We'll see. And the angiotensin to Athos trial, it has shown some benefit effect, but yet to see the trials. And the last one, the cytosol, extensively used in the COVID period because of cytochrome storm. Here, our institution guidelines says to check for the IL-6 levels, which I mean we take the mark of more than 100. If it is a hyper storm-like thing, we use with the RRT. Mortality benefit to come, only they are used in the ECMO and CABG patients. Thank you.